Tim. Quite fantastic presentation. We ran out of time, so we move to the next session.
Our next speaker will be Professor Neil Miller, who will speak on current and evolving therapies for optic pathway gliomas. Dr. Miller.
Thank you. It's a pleasure to be here with you. I want to thank Carmen and the rest of the group for inviting me to be here. I want to talk a little bit. Yesterday, those of you who were at the Walsh in Asia meetings heard a little bit about some of the new molecular genetic information on optic gliomas. I'm going to expand that a little bit to talk about the current management options that we now have. The main molecular pathways for cellular growth that people are discovering. I'm going to talk about the molecular genetics of NF1 related and sporadic optic pathway gliomas. And finally, I'm going to show you some of the targeted treatment options that there are that have really revolutionized what we do with these patients. Optic pathway gliomas, as you probably know, are the most common pathway tumor in children. They can occur in patients both with NF and with sporadically. And until recently, there were sort of limited options. Certainly, as was mentioned yesterday, a lot of these lesions do not grow, they do not cause severe visual loss, and the children can be observed. You don't want to excise them, in part because you'll blind the patient, and in part because we and others have shown that if you look at the end of cut sections of children who have undergone excision of the optic nerve because of severe proptosis or blindness with corneal problems, what you find is that there are glial cells, abnormal glial cells, beyond the margin of the cut, even though imaging doesn't show any abnormality. Radiation can certainly stabilize or improve patients with optic gliomas. However, you don't want to do them, if at all possible, in NF1 patients because they have a tendency to develop other tumors. And then there's non-specific chemotherapy, drugs like vincristine and carboplatin, vinblastine, actinomycin D, etoposide, etc., have been used. And some of these work really well. Here's a patient who has a dramatic response to standard chemotherapy. You see the lesion before treatment, and then after 1 year of treatment, just with vinblastine, dramatic response. This is terrific. On the other hand, this is the other end of it. The child who had a glioma was treated with standard chemotherapy, and you can see the growth of the lesion over time. So what can we learn from molecular genetics? Well, there are three proliferative pathways that are extremely important for cellular growth and tumor development. Certainly one is the RAS-RAF-MEK pathway. This produces, if stimulated, a growth differentiation. Then there's the PI3K pathway, which involves the torch studies, and finally the AKT pathway. And these are all, as I say, pathways that, when stimulated, when active, induce tumor development. So let's talk a little bit about the NF1 gene. You all know this is a gene on chromosome 17, the product of which is neurofibromin, which is an inhibitory protein. And patients with the NF1 gene, patients with NF1 have the gene in all cells of the body, but in one copy. If there's a somatic mutation, that's when the patient becomes symptomatic. And it turns out that neurofibromin has effects on two parts of the pathway. I already mentioned the RAS pathway, and here you can see in this little cartoon that if you have a problem with neurofibromin and you lack that gene, you stimulate, it's an inhibitory gene on the pathway, you stimulate the pathway, and eventually you wind up with a brain tumor. That's not the only effect. it has an effect on ATP, and it's inhibitory such that you get an inhibition of the transmission or transference from ATP to cyclic AMP, and once again, you have a stimulation of cellular differentiation. And this has been shown in conditional knockout animals. Here you can see a normal optic nerves and chiasm, and then in the animals without neurofibromin, you see a glioma of the chiasm. There is some early treatment that's targeted for NF1-related optic pathway gliomas. It's not much, but there was a phase 2 trial using the MEK inhibitor selumetinib that was approved by the FDA for plexiform neurofibromas, and many of our colleagues in orbital disease are using that now rather than surgery. But they looked at 25 children with progressive optic pathway gliomas who had failed up to 11 different types of non-targeted medication, and 6 of those patients, about a quarter, had a partial response. About half had stable disease. There were still some who progressed, 5 of the 25 children, but the majority either who had progressive disease, either stabilized or improved, and of 19 of these 25 patients in whom vision could be tested, a number of them showed improvement and a number were stable, and only 2 had worsened. So this has a lot of potential. Now, you heard Patrick talk about gene therapy, and certainly because this is a tumor suppressor gene that is lost, the neurofibromin, the optimum treatment probably would be gene therapy injected into the tumor itself. And there are, for those interested, is a lot of money out there to do research in this area. In fact, there is some research already ongoing in various animal models, including both primates and rodents. Well, what about sporadic OPGs? And here we have the importance of BRAF. BRAF, I mentioned the RAS-RAF pathway. The BRAF gene on chromosome 7 produces a protein kinase that's part of that pathway. And if you have increased BRAF in astrocytes, it causes activation down lower close to the final common pathway for cellular differentiation. And it turns out that if you look at sporadic optic pathway gliomas, about a third of them have a mutation at site 600, where V to E mutation that changes the triplet and changes the protein. In addition, about 60% of children with sporadic optic pathway gliomas have another type of genetic abnormality, a tandem duplication, again at the BRAF focus. So these are targets for inhibitors. And here's an example of one of our patients. This is treatment of this V600E positive optic pathway glioma with a BRAF inhibitor called dabrafenib. And you can see in the photographs above this dramatic, significant chiasmal glioma before dabrafenib. And then after a year of weekly dabrafenib, you can see the marked improvement in enhancement and decrease in the size of the tumor. This is a patient, these are 2 patients in the literature, again treated with a BRAF inhibitor, vemurafenib, and these were V600E positive, and you see the dramatic reduction, again, dramatic reduction not only in enhancement, but in size of the tumor. You can treat these patients with V600E negative findings. You can treat them with a combination of a BRAF inhibitor and a MEK inhibitor. And you can see in one of our patients the dramatic reduction in, again, enhancement and size of the lesion. This is another patient from the literature, optic pathway glioma, V600E negative, treated only with the MEK inhibitor trametinib. And before treatment, you notice the dramatic mass in the right orbit as well as in the chiasm, and again, the improvement after 18 months of treatment of the entire lesion. In fact, this has been so significant that in March of 2023 in the United States, the FDA approved the use of both dabrafenib and trametinib, so a BRAF inhibitor and a MEK inhibitor for pediatric patients with these gliomas that are V600E positive. And there's even a new oral formulation, so it's much easier for the kids to take. There are some adverse effects of these drugs, but they're pretty benign. Systemically, they're rash and pruritus, and some kids have a headache, a little fever, but it's not severe at all. Ocular complications do occur, conjunctivitis, mild uveitis, not requiring any treatment, and dry eyes. For the MEK inhibitors, the most common systemic effect is fever, but there are some others. There is a MEK-associated retinopathy, but as far as we can tell, it's fairly benign and very self-limited. So in summary, the molecular pathway is important in understanding the biology of both NF1-related and sporadic optic pathway gliomas. It's becoming more and more clear and providing us with an ability to treat patients who need treatment with targeted therapy rather than either allowing them to lose vision, following them without any treatment, or radiating them and with all the complications that radiation can eventually cause in children. And so I recommend to you that you stay tuned, because you will see more and more of this in the coming months and years. Thank you very much.